Face, lips, and palate. Development of the face. The human face is formed of fusion of 5 embryonic prominences. Each process is formed of a core of mesenchymal tissue, lined by epithelium of endodermal origin and covered by surface ectoderm. They encircle the stomatium, primitive mouse, one frontonasal process indented by 2 olfactory pits, dividing it into a median and 2 lateral processes. 2 maxillary processes, 2 mandibular processes will form the floor of the mouth, lower jaw, and lower lip. Development of the lips. Upper lip, formed of maxillary processes. The middle part of the upper lip, the philtrum, is formed of the median part of frontonasal processes. The lower lip, formed by fusion of the 2 mandibular processes. Development of the palate. Primary palate and secondary palate. Primary palate, the anterior part of the palate, and is also called the premaxilla. It carries the 4 incisor teeth, derived from the median part of the frontonasal process. Secondary palate. From each maxillary process, a palatal process grows medially across the dorsum of the tongue, forming the 2 palatal processes, the unit, with each other and with the premaxilla together with the nasal septum, separate nasal cavities from each other and form the oral cavity. Congenital anomalies. Cleft lip and cleft palate. The most frequent congenital anomalies of the face. 1 to 700 live birth. The incidence is less in black and oriental races. Periauricular sinus, due to imperfect fusion of the tubercles that form the ear auricle. When occluded, a cyst develop that might develop into abscess and leading to resistant ulcer. Dermoid cyst. Sequestration dermoid cysts occur at lines of embryonic fusion, the most frequent of which is the external angular dermoid. Pierre-Robin syndrome, consisting of cleft palate associated with receding mandible, micrognatha, and posterior displacement of the tongue, which is prone to obstruct the oropharyngeal airway. Mandibular prognathism. Definition: protrusion of the mandible. Cleft lip or hair lip. Etiology: familial disease due to genetic susceptibility, consanguinity, prenatal exposure to alcohol, anticonvulsants, X-ray, virus infection, such as German measles in the first 3 months of pregnancy. Pathology: failure of fusion between the median part of the frontonasal process and one unilateral or both bilateral lateral maxillary processes in the developing face. The cleft can be complete, reaching the nostril floor, or incomplete. With complete lip clefts, the orbicularis oris muscle is completely interrupted, leading to flaring and flateness of the nares on the affected side. The cleft lip may be isolated or associated with cleft palate or alveolus. Cleft lip doesn't interfere with suckling, and it may be associated with abnormal teeth growth. Cleft lip associated with other congenital anomalies in 35% of cases. Treatment: surgery, the only treatment. Timing: best performed at the age of 3 to 6 months. Principles of operation: paring of the edges, repairing the defect by suturing the 3 layers of the lip, skin, muscle, and mucous membrane, taking care to adjust the vermilion and the mucous borders. The sutures are not made in a straight line but zigzag way to avoid notching of the lip margin as the scar contracts. Cleft palate. Etiology: the same as for the cleft lip. Pathology: arrest of fusion between the 2 palatal processes with the premaxilla. Types: cleft soft palate, cleft soft and hard palate, complete cleft palate plus one side of the premaxilla, bipartite, complete cleft palate plus both sides of the premaxilla. This is called tripartite. Effects on function: inability to create negative intraoral pressure because of the oronasal communication, leading to impairment of normal suckling. Food will reflux into the nose, aspirated, leading to aspiration pneumonia. Inadequate emptying of the middle ear due to abnormal levator palate insertion prevents eustachian tube adequate aeration. Recurrent otitis media and hearing loss occurs. Speech defects secondary to inadequate velopharyngeal mechanism, opposition of the velum, the muscles of the soft palate, against the pharyngeal wall to separate the oral from the nasal cavity is impaired. Nasal tone is due to nasal-oral communication. Hearing loss, distortion of facial growth, interference with normal teeth alignment. Treatment: timing of the operation 12 to 18 months. Preoperative management: attention to feeding in an upright position. Feeds are given whether by a bottle with a large hole or with a spoon. Prevention and treatment of chest infections. Objectives of surgery: closure of oronasal communication, achieving a competent velopharyngeal sphincter. Principles of surgery: trimming of edges, suturing in 3 layers in the middle line, nasal mucosa, muscle and oral mucosa. Lateral relaxation incisions are needed. Fracture of the pterygoid hamulus to relax the tensor palati. Post-operative treatment: speech therapy and orthodontic treatment. Maxillofacial injuries incidence frequent with road traffic accidents, fights, and contact sports. The order of priorities in treatment of patients with extensive injuries: patent airway, upper airway can be obstructed by blood, dentures, or vomits. Tracheostomy is rarely indicated. Effective breathing, controlling hemorrhage by direct pressure or ligation of the bleeding vessels. If the patient is shocked, suspect associated abdominal or chest injuries. Isolated facial injuries rarely cause shock. Soft tissue injuries. For the skin, we have minimal wound debridement, cut wounds and lacerations, they are sutured. Avulsed flaps, sutured after entering vascularity at the tip. If there are skin defects, local flaps or skin grafts. Lips, sutured in 3 layers with respect to anatomical landmarks. Nasal injuries, nostril tears, sutured in 2 layers. If septal hematoma is not evacuated, septal cartilage resorption leading to saddle nose deformity. Eyelid injuries, careful suturing of all lid layers. If cut levator not repaired, this leads to ptosis. The tarsus should be also repaired. Ear injuries, full thickness tears are sutured by cutaneous perichondrial sutures. If hematoma is not evacuated, this leads to cauliflower ear. Animal and human bites, usually heavily contaminated. Treatment: prompt excision, antibiotics, and rabies vaccination for animal bites. The wound is left open. Parotid injury, duct injury, end-to-end anastomosis over a small celastic castor. Distal part of the duct, proximal cut end, is sutured to the mucosa. Gland injury, skin is sutured and small drain is inserted. There will be salivary leakage, which usually stops in 3 weeks. Mandibular fractures, site in the body, the commonest: symphysis, angle, ramus, condyles, crinoid, or alveolar process. In bilateral cases, the digastric and genohyoid muscles pull the chin fragment and attach the tongue backwards, impair the airway. Fractures of the angle are minimally displaced as they are splinted by the masseter and pterygoid muscles. Fractures of the body usually occur close to the mental foramen, where the bone is weakened by the marked curvature and the deep canine socket. Clinical picture: symptoms: pain, especially on attempts to open the mouth, blood-stained saliva, impairment of speech and swallowing, anaphysia of the lower lip sometimes. Fractures of the mandible are usually compounded into the mouth because the mucoperiosteum is firmly attached to the bone. Signs: crepitus, local tenderness, swelling and hematoma in the floor of the mouth, irregularity of the line of the teeth. Investigations: plain X-ray, diagnostic, CT may be needed. A panoramic view shows the whole mandible. Treatment: first aid treatment: jaw is supported with 4-tailed bandage and give analgesics for pain. Antibiotics and mouth hygiene are important to prevent infection. Reduction and fixation done under anesthesia. Indications: there is displacement. Fixation for 3 to 6 weeks is done by arch bars, interdental wiring. The patient's jaw are wired together and given a liquid diet, appropriate for the majority of lower jaw fractures. Plate and screws for more complicated fractures. Fractures of the maxilla, clinical picture: pain, excess salivation, malocclusion, epistaxis, diplopia, swelling, and crepitations. Investigations: X-ray or CT scan. Classifications: we have Lefort classification. Maxillary fractures are divided into 3 types. Lefort 1, a transverse fracture above the level of the teeth. Lefort 2, a pyramidal fracture traversing the base of the nose through the posterior wall of the maxillary antrum and across the orbit. Lefort 3, there is craniofacial disjunction, separation of the facial bones from their cranial attachment. Temporomandibular dislocation, etiology: direct blows, yawning, wide opening of the mouth under anesthesia, commonly bilateral and affecting middle-aged females. Clinical features: pain and dysarthria. The mouth is held open with fixed jaws. In unilateral causes, the chin is deviated to the opposite side. And treatment: reduction, better under anesthesia method, downward traction on the molars with the padded thumb, with upward rotation of the body with the outside fingers. Infections of the face, dangerous area of the face. Definition: the area of the face between the lines passing from the outer canthus to the angle of the mouth, named so because infection in this area, as boils or carbuncles, is liable to cause cavernous sinus thrombosis. Route of spread: ophthalmic veins or the pterygoid plexus and Matary veins traverse the skull base to the cavernous sinus. Lip cancer, etiology: prolonged exposure to ultraviolet rays of the sun or chronic smoking. Pathology: histological picture: squamous cell carcinoma, the commonest, and they are well differentiated. Gross picture: the side of the lower lip is more affected than the upper. The lesion usually starts as nodule or erosion which resists treatment. Later, the typical ulcer becomes evident: raised everted edges, indurated basal margin, induration extending beyond the edge, possibly spread to the cervical lymph nodes. The central part of the lower lip leads to submental nodes, while the lateral parts goes to submandibular nodes. Upper deep cervical lymph nodes in both. Treatment: primary tumor, surgical excision of the lesion with safety margin or radiotherapy. Squamous cell carcinoma is radiosensitive. Lymph nodes: if there are lymph node metastasis, suprahyoid or complete dissection. Prognosis: epitheliomas of the lip have better prognosis than those in the rest of the oral cavity. Nose fractures: clinical picture, pain, swelling, epistaxis and crepitus. Investigations: plain X-ray. Treatment: reduce the fracture by hand or using an instrument to fix position by intranasal packing for 3 days with an external splint for 7 days. Lygoma fractures: clinical pain, swelling, clinical picture, pain, swelling of the eyelids, flat cheek, crepitus, numbness of the cheek and upper teeth due to infraorbital nerve injury with irregular infraorbital margin. Blowout fractures. Definition: orbital flow, depressed fractures with herniation of some of the orbital contents into the maxillary sinus. Cause: sudden increase in the intraorbital pressure. Clinical picture: diplopia and limited up and down gaze with or without enophthalmos. Mouth, cheek, and tongue. Stomatitis. Predisposing factors: anemia, vitamin B12 deficiency, thin atrophic epithelia, and loss of tongue papillae. Immunodeficiency and autoimmune diseases. Types: aphthous stomatitis, herpes simplex infections, Munerial stomatitis. Aphthous stomatitis: painful ulcers up to 0.5 cm across, round or oval with a yellow base and red margin. They heal normally within 10 to 14 days. Herpes simplex infections: small vesicles appear and rapidly break down to form small yellow ulcers with bright red margins. Site: gingiva, cheeks, lips, tongue, and skin of the cheek and around nostrils. The patient is unwell, febrile with enlarged submandibular lymph nodes. Munerial stomatitis: this is a fungus infection by Candida species. Clinical picture: formation of white membranous lesions. Type of the patient: debilitated, chronically ill patients under cytotoxic drugs, cortisone therapy, or prolonged broad-spectrum antibiotics. It affects mainly the tongue. Treatment by gentian, violet, and amphotericin B. Cysts in the floor of the mouth. Mucus cysts of the minor salivary glands. Either retention cysts behind minute calculi or extravasation cysts. They form soft pinkish or bluish swellings up to 1.5 cm in diameter. Treatment: excision. Ranula. Definition: retention cyst arising from a sublingual salivary gland. Saliva distends cyst in the floor of the mouth. Pathology: wool is composed of a thin fibrous capsule lined by macrophages. It may contain gelatinous material. If it extends down into the neck over posterior margin of the myelohyoid diaphragm of the mouth, a plunging granula, and it may rupture but usually refills again. Clinical picture: translucent bluish cystic swelling with prominent blood vessels running over its surface with stretched submandibular duct. Treatment: excision of the sublingual gland with the cyst is very difficult as the wall is thin and adherent. Marsupialization: partial excision of the roof, then suturing the edges to the mucosal lining of the floor of the mouth. This is a treatment of choice. Lingual and sublingual dermoid. Clinical picture: opaque swellings lined by stratified squamous epithelium. Pathology: the cysts are filled with mucus, fluctuant, or with a doughy mass of keratin. Site: there are found in the midline of the tongue and in the floor of the mouth, whether in midline, the commonest, or laterally in the submandibular region. Presentation: after puberty, although congenital. Treatment: excision through the floor of the mouth, if large, submandibular incision. Developmental anomalies of the tongue. Macroglossia. Definition: persistent, painless enlargement of the tongue. Causes: congenital and acquired such as cretinism, acromegaly, and amyloidosis. Congenital causes: neurofibromatosis, lymphangioma, congenital AV fistula, and cavernous hemangioma. Tongue tie. Etiology: short fibrous lingual frenulum. Effect: impairment of tongue movements and speech defects. Treatment: division of the frenulum below the undersurface of the tongue. Congenital fissure tongue. Fissures run transversely from a median groove, unlike those of syphilis, which are longitudinal. Inflammation of the tongue. Glossitis. Chronic superficial glossitis. This is precancerous. Chronic irritation and smoking. Sharp tooth. Sepsis, syphilis, and spices. It occurs in middle-aged and old-aged people. Pathology: there will be hypertrophied papillae, leukoplakia, red glazed tongue, cracks, fissures, and warty projections. Hypertrophy of the papillae produces red hyperemic patches. Overgrowth of the epithelium makes it thickened, indurated, and opaque so that the red patches are replaced by white ones, and tongue appears as if it's coated with white paint such as leukoplakia. In the next stage, epithelium may be shed over by considerable amount, leading to red glazed tongue. Submucous fibrosis occur leading to ulcers, fissures, and warty projections. Treatment: elimination of the irritating source, mouthwash, and in resistant cases, excision of the lesion. Tongue injuries. Etiology: biting of the tongue. This is the commonest, as in epileptic patients during attacks, or with jaw fractures due to road traffic accidents. Complications: damage to the lingual artery, bleeding, endanger the airway in unconscious patients. Treatment: arrest bleeding by hooking the tongue forwards and with finger compressing it against the mandible, then suture the lacerations in the OR. Tongue ulcers. Dental ulcer or aphthous ulcer. Dental ulcer. Etiology: repeated trauma by broken tooth or ill-fitted denture. Site: at the side of the tongue, near the offending tooth, might not be apparent when the tongue is protruded for inspection. Gross picture: the ulcer is small, oval or rounded with granulation tissue at the floor, soft base and sloping margins. Clinical picture: painful with septic enlargement of the draining lymph nodes. In chronic cases, the edges may be raised with indurated base. Biopsy is needed to exclude malignancy. Treatment: removal of the offending cause and using antiseptic mouthwash. Aphthous ulcer. Etiology: not exactly known. Pathology: multiple small ulcers affecting all mucosal lining of the oral cavity with red margin and soft base. Clinical picture: very painful, rounded, yellow ulcers without lymph node enlargement. Site: near the tip of the tongue. Treatment: normally heal in 2 weeks by antiseptic mouthwash, alkaline lotion as 2% sodium bicarbonate and anesthetic gel. Neoplastic ulcers, usually squamous cell carcinoma. Carcinoma of the tongue. Incidence: usually above 60 years of age. Nowadays is usually slightly higher in males. The recent lowering of the incidence in males is due to more efficient treatment of syphilis, improved oral hygiene, discontinuation use of clay pipes, and reduced alcohol consumption. Recent increased females incidence is due to increase of smoking. Etiology: predisposing factors, chronic irritation by smoking, sepsis, spices, spirits, sharp teeth, and bad oral hygiene. Precancerous lesions. Dental ulcers, chronic superficial glossitis, leukoplakia, any white lesion which cannot be rubbed off. Pathology. Site: lateral margin of the anterior 2/3. This is the commonest, 50% of cases. The posterior 1/3, the second common. The ventral and dorsal surface, and finally the tip, which is rare. Gross types: malignant ulcer with deep irregular floor with necrotic tissues, raised nodular everted edges, and hard indurated mass. Raised oval plaque, diffuse infiltrating tumor, wooden base is rare. The surrounding mucous membrane may show leukoplakia. Carcinoma in situ means evidence of malignant cells without invasion of the basement membrane, no lymphatic or blood spread. Microscopic appearance: squamous cell carcinoma 90%. Tumors of the posterior third are usually less differentiated. Spread: direct, blood and lymphatic. Direct: tumors of anterior 2/3 laterally and may reach the floor of the mouth before they cross the midline, may invade the mandible. Tumors of the posterior 1/3 to the tonsils, pharyngeal wall, and larynx, may cross to the other side of the tongue. Blood spread: rare, more in tumors of the posterior third. Lymphatic spread occurs early on the tip of the lung, submental lymph node, bilateral to submandibular, upper deep cervical lymph nodes, and of the lateral third, ipsilateral submandibular, then upper deep cervical lymph nodes. Those near the midline disseminate bilaterally. Posterior third, directly to the upper deep cervical lymph nodes. Complications of the carcinoma of the tongue: inhalation of necrotic tissues leading to bronchopneumonia, combined cancer cachexia and starvation due to pain and dysphagia, hemorrhage from lingual artery erosion, asphyxia due to pressure of enlarged fixed lymph nodes on the air passages or due to edema of the glottis. Clinical picture: early cases symptomless. Patient may complain of persistent ulcer with indurated base and everted edges. Late presentation: pain in tongue, first due to infection and later due to lingual nerve infiltration. Referral to the ear or temple through the chorda tympani by the auriculotemporal nerve. In tumors of the posterior third, pain may be felt on swallowing. Salivation due to the pain plus restricted tongue mobility. It may be blood-stained and smells badly, necrosis and infection. Inability to articulate clearly. Enlarged cervical lymph nodes and ankyloglossia, tongue fixation due to extensive infiltration of the floor of the mouth. The classic picture of tongue cancer is that of an old man sitting in an outpatient clinic with cotton wool in his ear and blood-stained saliva dripping from the mouth. An ulcer or fissure-like lesions which resist treatment should be biopsied. Investigations: CT of the neck and mandible, biopsy of the ulcer edge, and fine needle aspiration cytology of suspected cervical lymph nodes. Treatment: radical treatment for early cases. Surgery. Indications: small growth, T1 and T2, incomplete regression or recurrence after radiotherapy, cancer on top of precancerous lesion as leukoplakia, presence of the tumor very close to the mandible or infiltrating it, preoperative preparation, care of the teeth, and oral hygiene. Preoperative irradiation by 4,000 rad may be advised. Surgery and radiotherapy are the main lines of treatment. Chemotherapy is used as an adjuvant in some cases. T&M staging for tongue carcinoma. T0, no evidence of tumor. TIS, carcinoma in situ. T1, less than 2 cm. 2, from 2 to 4 cm. T3, more than 4 cm. T4, involvement of the base. N0, no lymph nodes, and 1 ipsilateral single node, less than 3 cm. N2, ipsilateral or contralateral lymph nodes, less than 6 cm. N3, lymph nodes more than 6 cm. M0, no metastasis. M1, distant metastasis. Resection procedures for the treatment of the carcinoma of the tongue: excision with a safety margin of 1.5 cm, partial or near total glostectomy. If there are metastatic lymph nodes, modified neck dissection. If the mandible is affected, excise together with the tongue and the affected lymph nodes. Combined mandibulectomy and neck dissection operation is known as commando operation. Close the huge defects following major resectional operations on tongue, floor of the mouth, and mandible by various plastic procedures as pectoralis major myocutaneous flap. Radiotherapy indications: T1 and T2 less than 4 cm equally benefit from surgery or radiotherapy. Advantages: avoiding the disfiguring side effects of surgery. Disadvantages: mucositis, dysphagia, and osteoradionecrosis. Carcinoma of the cheek as cancer of the tongue. Etiology: predisposing factor, chronic irritation by smoking, sepsis, spices, spirits, sharp teeth, and bad oral hygiene. Precancerous lesions: dental ulcers, chronic superficial glossitis, leukoplakia, any white lesion which cannot be rubbed off. Pathology: squamous cell carcinoma, the commonest. Adenocarcinoma of minor salivary glands, less common. Clinical picture: ulcerated mass with raised everted edges and indurated nodular floor. Treatment: interstitial or external beam radiation, treatment of choice, plus surgery. Indications: recurrent or residual tumors, followed by reconstruction as for the tongue cancer. Lymph node metastases are treated by neck dissection. The neck. Anatomical divisions of the neck: triangles. Each side of the neck is divided by sternomastoid muscle into posterior triangle and anterior triangle. The anterior triangle is further divided into submandibular triangle, carotid, and muscular triangle. Submandibular triangle boundaries are: from above, the body of the mandible; posteriorly, posterior belly of digastric; and anteriorly, anterior belly of digastric. Carotid triangle, whose boundaries are: posteriorly, sternomastoid; superiorly, posterior belly of digastric; inferiorly and anteriorly, superior belly of omohyoid. Muscular triangle, whose boundaries are: posteriorly, sternomastoid; superiorly, superior belly of omohyoid; and anteriorly, the middle line. The two muscular triangles form together a diamond-shaped area. Compartments: in a cut section, the neck is divided into two compartments: musculoskeletal compartment, lying posteriorly, separated from the visceral compartment by thick fascia, the prevertebral fascia. The visceral compartment, lying anteriorly and enclosed in the investing fascia of the neck, contains esophagus, trachea, thyroid, parathyroid glands, carotid arteries, vagus nerve, jugular veins. Because it's enclosed within such a fascial covering, a swelling in this visceral compartment leads to pressure symptom and signs as dysphagia, dyspnea, and weak carotid pulse. Neck injuries. Etiology: penetrating injuries, more common by gunshots or stabs. Blunt injuries, usually secondary to road traffic accidents, and may cause spine fracture. Neck injuries are serious because neck contains vital viscera and vessels. Unstable cervical spine fractures and dislocation can cause paraplegia, quadriplegia, or immediate death. Neck injuries are commonly associated with head, face, and chest injuries. The most commonly injured structures are in that order: big vessels, spinal cord, and aerodigestive tract. Clinical picture: vascular injuries present by hemorrhage, may be severe enough to cause shock. Expanding hematoma. Injury to large vein may lead to pulmonary embolism. Neurological injuries: fracture of the cervical spine leading to quadriplegia or paraplegia. Injury to the brachial plexus or cranial nerves. Injuries to the larynx or trachea may present by respiratory obstruction, aphonia, hoarseness of voice, subcutaneous emphysema, air bubbling through the wound or hemoptysis. Esophageal injuries: leakage and severe infection in the neck and spread to mediastinum. Investigations: plain X-ray may reveal foreign body, wide mediastinum, subcutaneous emphysema, fractures. Duplex ultrasound: injury to the big vessels. CT of the skull and brain, CT angiography. For laryngeotracheal injuries, laryngeoscopy and bronchoscopy. For esophageal injuries, gastrography and swallow. Treatment: ABCDE of the trauma must be followed. Airway management, especially endotracheal intubation, can be both difficult and dangerous, done by the most experienced personnel. Cricothyroidotomy may be easier and safer than tracheostomy. Trendelenburg position: avoid air embolism in major venous injuries. IV lines should be avoided in the side of the trauma. Tension pneumothorax, managed by inserting needle in the second intercostal space. External bleeding, minor, local compression, major, exploration to stop bleeding and perform repair. In cases of neurological damage, neck support and evaluation of the patient, initially according to the Glasgow-Coma scale, then by CT and or MRI to define the neurological lesion. Esophageal injury, if discovered early, immediate exploration and repair. Laryngeotracheal injuries, surgical repair. Then we have cellulitis of the neck. Superficial cellulitis, common and diagnosed and treated as cellulitis anywhere. Deep cellulitis or Ludwig's angina. Pathology, inflammatory swelling of both submandibular region and mouth cavity due to deep cellulitis around the submandibular gland, usually due to streptococcal infection, deep to the deep fascia, spreading to the glottis, leading to edema and asphyxia. Clinical picture, inflammatory swelling in the submandibular region, which is painful, red, warm, tender, and overlying skin is edematous. Swelling of the tongue, which is pushed upwards and forwards. Treatment, urgent antibiotics and drainage through incision beneath the jaw. Incision deepened to permit displacement of the submandibular salivary gland and division of myelohyoid muscle for adequate drainage. Cervical lymphadenopathy, half of the lymph nodes of the body are present in the neck, drain the head and the neck. In addition, the supraclavicular nodes are secondary stations for the apex of the lung, upper limbs, abdominal viscera, and testis. Accordingly, cervical lymphadenopathy is very common. Differential diagnosis of neck swellings, midline swellings, solid swellings such as submental lymph node enlargement, nodule in the isthmus of the thyroid gland, cystic swellings, dermoid cyst, thyroglossal cyst moving up and down with deglutition, also moving up with tongue protrusion, subhyoid bursitis, rare, tender, overswelling which lies transversely below the hyoid, moving up and down with deglutition and with tongue protrusion, cyst in the thyroid gland, laryngeocele, rare swelling in the musicians who play air-blown instruments, and its herniation of the laryngeal mucosa through thyroid membrane. It's compressible, increases in size with coughing or blowing. Swellings in the submandibular triangle, enlarged submandibular lymph nodes, multiple and can be rolled over the edge of the mandible, enlarged submandibular salivary gland. Swellings in the carotid triangle, solid, such as enlarged upper deep cervical lymph nodes, carotid body tumor, cystic swellings called abscess and branchial cyst. Swellings in the posterior triangle, sold swellings, enlarged lymph nodes, cervical rib, neurofibroma arising from the brachial plexus, cystic swellings, cystic hygroma, called abscess, pharyngeal pouch, pneumatocele caused by herniation of the pleura into the base of the neck, cystic swelling in the supraclavicular region, resonant and compressible. Other swellings which may arise anywhere, lipomas, sebaceous cysts, hemangiomas, they are swellings of the skin and subcutaneous tissue and they are common in the neck. Carotid body tumor incidence, rare, slowly growing malignant tumor, origin from the chemoreceptors at bifurcation of the carotid artery. Clinical picture, slowly growing, swelling at the middle-aged persons, which is usually smooth but may be lobular, swelling moving from side to side but not vertically, exhibiting transmitted pulsations from the underlying carotid artery. Investigations and geography, splaying the bifurcation, biopsy, even with a fine needle is contraindicated as tumor is highly vascular. Treatment, excision with preservation of the internal carotid artery. If not possible to separate the tumor from the ICA is excised and replaced by a synthetic graft. Thoracic outlet syndrome, anatomy. The brachial plexus and subclavian artery pass to the upper limb through a narrow triangle in the base of the neck. This triangle bounded anteriorly by scalenus anterior, posteriorly scalenus medius, and inferiorly the first rib. At this narrow space, compression of nerves and arteries occur, leading to symptoms and development of thoracic outlet syndrome. Etiology, cervical rib, complete or incomplete, bony structure extending from the seventh cervical vertebra to the first rib. A fibrous band extending from an incomplete cervical rib, which ends at the first rib. Tight scalene muscle, post-fixation of the brachial plexus, where the lower root of the brachial plexus, arising from T2 instead of T1, T2 becomes excessively stretched over the first rib. Pathology, brachial plexus, the lower trunk is the main structure to be compressed. It contains sensory fibers to medial aspect of the hand and the forearm, motor fibers to small muscles of the hand, and most of the sympathetic fibers of the upper limb. Subclavian artery, less common to be compressed, leads to chronic ischemia of the upper limb. Post-stenotic dilatation of the artery segment immediately following the compression. Post-stenotic dilatation, thrombus inside, may send a shower. Emboli to the index and middle fingers, they are direct continuation of the brachial artery, leading to digital gangrene. Subclavian vein. Its compression leads to subclavian and axillary vein thrombosis, chronic venous insufficiency of the upper limb. Clinical picture. Type of the patient more frequently in females, rarely develop before adulthood, usually unilateral, affecting dominant arm but sometimes bilateral. Differential diagnosis. Other causes of localized pressure on the nerve. Cervical spondylosis, carpal tunnel syndrome. Other causes of Raynaud's phenomena, Raynaud's disease, SLE, and other collagen diseases as they may be associated with vasculitis. Symptoms. Nerve compression symptoms, the commonest, tingling and numbness in the medial aspect of the forearm and head due to compression on the lower root of the brachial plexus. Arterial symptoms, intermittent claudication pain in the upper limb with exercise. Raynaud's phenomena occurring in cold weather. Attacks of pallor in fingers followed by cyanosis, then redness. Rebound hyperemia due to irritation of sympathetic fibers supplying the upper limb. Venous symptoms, rare. Subclavian vein thrombosis, acute upper limb pain and swelling. Chronic heaviness and swelling leading to chronic venous insufficiency. Signs. Hypothesia may be detected in the medial forearm and head. Mild wasting of hand muscles. Weaker radial pulse than the opposite side. Cervical limb bony swelling at the base of posterior triangle, which is rare. Adson's test. It's not very accurate. It may demonstrate compression of the subclavian artery. Ask the patient to extend his head, look at the opposite side, take a deep breath, then palpate the radial pulse while the arm is pulled down. If the test is positive, the radial pulse strength is reduced. Investigations. Plain X-ray to the neck. Bony cervical rib, nerve conduction study between the neck and the forearm, detect delay in conduction and differentiate between thoracic outlet and carpal tunnel syndromes. Radiographic discovery of a cervical rib in asymptomatic person deserves no treatment. Treatment. Early cases, conservative, physiotherapy, strengthen shoulder muscles, relieve symptoms, failure of conservative treatment, surgery aimed to relieve compression. Methods. Excision of a bony cervical rib, division of the scalenus anterior muscle, scalenotomy to relieve the compression anteriorly, excision of the first rib to relieve the compression inferiorly, very efficient and can be done through transaxillary approach. Radical block neck dissection. Definition. Removal of all lymph nodes on one side of the neck and in one mass on block. Aim. Eradication of the malignancy aiming at cure, achieved by removing the first lesion and its lymph node metastasis. Indications. Operable. Primary malignancy of head or neck with palpable malignant cervical lymph nodes. This is the main indication. Prophylactic radical block neck dissection in cervical nodes are impalpable. Indications. Malignancies that are known of their high tendency to lymphatic spread as carcinoma of the tongue and melanoma. In other types of malignancy, if lymph nodes are not palpable, the primary is removed, then follow up the patient every 2 months. If lymph nodes become enlarged, block neck dissection. The two most frequent neck swellings are lymph node enlargement, acute lymphadenitis, chronic lymphadenitis. Commonest is non-specific. Keep in mind, more serious causes like TB, Hodgkin disease, and secondaries. Secondaries may arise from hidden malignancies such as nasopharynx, pariform fossa, nasal sinuses, thyroid papillary carcinoma, and finally, thyroid enlargement, goiter. And this concludes face, lips, palate, mouth, cheek, tongue, and the neck.